Welcome to the USMLE Step 2 Success podcast. I'm Dr. Rajani Katta, author of the Successful Match book, and in this podcast, I share clinical cases with targeted teaching points. This podcast is not affiliated in any way with the National Board of Medical Examiners, and cases and teaching points are not meant to serve as an official study guide or medical guidance. I've been a faculty member for over 20 years, and I've advised hundreds of residency applicants. I know how important standardized test scores are in the application process, although I always remind my students that they're just one piece of the application puzzle. If you'd like to learn more on how to succeed in the residency match, you can sign up for a free 100-page excerpt of the Successful Match book on our website, thesuccessfulmatch.com. It's a Wednesday afternoon and you're working in the family practice clinic. As you go in to see your next patient, your nurse tells you that this patient is an add-on. He's a patient that's well known to you. It's Mr. John Lane, and he's a 65-year-old male who works as an accountant. He has diabetes, which has been well controlled with oral medications. As you walk in to speak to the patient, he tells you that he had to come in because he's been experiencing right lower leg pain that's just been continuing to worsen over the previous 3 days. As you ask him more about it, he tells you that there was no injury, nothing like that. He's just been going to the office all week. As you examine the leg, you note that it is warm, red, edematous, and is tender to the touch. He does have good sensation in the area, and he has good pulses. You compare it to the left leg. The left leg is not edematous, there's no redness, there's no scaling. His vital signs are stable. He tells you he doesn't have any systemic symptoms, and you note that he has no fever. What is the most likely diagnosis here? Are you dealing with chronic venous stasis? Are you dealing with contact dermatitis? Is this cellulitis, or is it necrotizing fasciitis? And after that, we're going to talk about the best initial steps. Well, the most likely diagnosis here is cellulitis. Cellulitis is an acute bacterial infection that involves the dermis and the subcutaneous tissues of the skin. In cellulitis, you're not going to see an abscess or a collection of pus. It's going to be a poorly demarcated area. The 4 classic clinical features are going to be that it's red, warm, edematous, and painful. You need 2 of these features to make the diagnosis of cellulitis. Now, some of these patients may have fatigue or they may have fever, indicating more systemic involvement, but typically most patients are going to have this infection limited to the skin. Now, the next question to ask here is, what would be the best next step? Would it be to start antibiotics? Would it be to take a tissue aspirate for culture? Would it be imaging studies with a Doppler ultrasound, or would it be imaging studies with an MRI? Well, the best next step is to go ahead and start antibiotics. The diagnosis of cellulitis is a clinical diagnosis. You do not need a culture in order to start treatment, and imaging isn't necessary either. Now, the next question to ask here is, what antibiotics would you start? Well, in this case, you have to go back to the most likely pathogens. So with cellulitis, in a patient like this, we know he's diabetic, but he hasn't given us any unusual exposure histories in terms of type of injury or a type of exposure. And he has diabetes, but he's not immunocompromised in other ways. So the most likely pathogen is going to be typically a beta hemolytic strep, generally group A. So that would be your strep pyogenes. Another possibility would be a Staph aureus. Those are far and away the two most likely pathogens. So when you're talking about your best initial antibiotic therapy, are you thinking about ciprofloxacin? Are you thinking about linezolid? Are you thinking about cephalexin? Or are you thinking about doxycycline? Well, in a patient who's not allergic to penicillin, the best initial treatment would likely be either a cephalosporin or a penicillin. So you could use cephalexin or dicloxacillin. Now, if the patient was allergic to penicillin, then typically you're going to use either clindamycin or erythromycin or clarithromycin. Now, there are some special situations here where your choice of antibiotic would be different. So, for example, if the patient is, for example, had a history of intravenous drug abuse or was considered at high risk for MRSA, methicillin-resistant Staph aureus, then your options would change. Then instead of doing something like a cephalexin or a dicloxacillin, you would go straight to either clindamycin or doxycycline or trimethoprim sulfamethoxazole. And your choice of antibiotic here, if you believe that the patient is at risk for MRSA, that choice of antibiotic would really depend on the local sensitivity patterns, depending on antibiotic resistance patterns in your own community. Now, what if the question asked if this patient had systemic involvement? You've already taken your blood cultures, but let's say you need to start treatment and this patient is severely immunocompromised or has evidence of systemic infection. Well, in that case, if you're suspecting that it might be a methicillin-sensitive Staph aureus, you could do IV cefazolin, or if you believe you might be dealing with an MRSA, you might have to do IV vancomycin. But let's go back to Mr. Lane for a moment. The best initial step would be to start oral antibiotics because this is a clinical diagnosis and there's no culture needed. But there are a few additional things you need to do here. In addition to starting treatment, you want to make sure that you mark the borders of the cellulitis, or you want to make sure that you mark the borders of the areas of involvement, because this patient should be improving within 24 to 48 hours. If the patient comes back to you on Saturday morning and says, I'm just not getting better, you'll then have your borders marked out so that you can really see if that cellulitis is progressing. And if the cellulitis is progressing, then perhaps you're dealing with a resistant organism, and then you're going to have to adjust that initial antibiotic therapy. In addition, it's really important that you look for a portal of entry. So the patient didn't have any obvious injury, but a lot of times cellulitis develops because there is some break in the skin that has served as a portal of entry for bacteria. And that portal of entry could be pretty minimal. So a lot of cases in your diabetic patients, it's really important to look between the toes because a lot of times that portal of entry is tinea pedis. So if they have a fungal infection of the toes, typically what happens is you get redness and scaling and maceration, sort of raw skin interdigitally. So if you look, especially between the fourth and fifth toe webs, you'll often see that redness and scaling and maceration. And that frequently serves as a portal of entry for bacteria to trigger a cellulitis of the lower leg, and especially in a patient with diabetes. So that's something really important that you're going to look for. You're going to spread open the toe webs and look, because if they have tinea pedis, then that's something that needs to be treated. It's also important to look for other breaks in the skin. Sometimes people have chronic venous stasis dermatitis, and the clinical appearance of that is a bilateral involvement, classically with some edema, because these patients have chronic venous stasis, which causes edema. And in that setting, they often develop dermatitis, which is an inflammation of the skin. And when you get dermatitis, you'll often see redness and scaling. Sometimes you'll see hyperpigmentation and hypopigmentation. But because you have that dermatitis, that inflammation, it actually serves as an impaired skin barrier. So it is easier to develop a secondary infection in the setting of an impaired skin barrier. So there could be a number of reasons why your patient is more prone to cellulitis. I already alluded to this, but it's very important in any patient with cellulitis that you look for evidence of systemic infection. The systemic constitutional symptoms or that fever. You also need to determine if your patient is immunocompromised, because that might alter your next steps there. In patients such as that, it would be important to get a blood culture and to draw labs and to think about how you would alter your initial antibiotic therapy. And that might also change your thoughts on what the most likely pathogen is. I already mentioned that the patient had good pulses and good sensation. And that's because I was on the lookout for necrotizing fasciitis, which is a surgical emergency. So let's talk a little bit about skin infections, because your clinical manifestations are going to determine at what level of involvement that skin infection is. So the most superficial involvement would be impetigo, and that's your golden honey-colored crusting. So that's very superficial infection. What is the best treatment for impetigo? Well, that can be treated with topical antibiotics, typically your topical mupirocin. Erysipelas is a little bit deeper in the skin. Erysipelas is a more superficial infection that typically is going to involve the upper dermis and the superficial lymphatics. And in erysipelas, you're typically going to have, yes, a bright red area, but it's typically going to be elevated and well demarcated. It's just more superficial. Cellulitis is a little bit deeper. As I mentioned, you're going to have involvement of the dermis and the subcutaneous tissues. Necrotizing fasciitis is going to be your deepest involvement, and that's going to actually involve the fascia. So if you think about the anatomy of the skin, you've got the epidermis, the outermost layer, then you've got your dermis, then you've got your subcutaneous tissue, then you've got your fascia, which is that layer that's covering your muscle, and then you've got your muscle. So necrotizing fasciitis is the deepest involvement, and that's a surgical emergency. Finally, you also need to know about recognizing and treating a skin abscess. So a skin abscess is a collection of pus within the dermis or the subcutaneous tissue. And a skin abscess typically is going to present as that red fluctuant nodule. Classically, it's going to be due to Staphylococcus aureus. It could be MSSA or it could be MRSA. But an abscess may be treated a little bit differently, because if it is fluctuant, if you can actually feel that collection of pus, your classic treatment is going to be an incision and drainage. Now, in that case, if you're going to incise and drain out the pus, you are going to send that for culture. And that's going to be easy to get a culture specimen. You're just going to swab that. And then you're going to treat that patient for the Staph aureus. There are a number of different clinical scenarios that would be different from your typical cellulitis patient. So what I'm going to do in the next episode is quickly run over 8 different scenarios of cellulitis or cellulitis mimickers that you need to be able to recognize for the boards. And some of these are kind of your classic board questions that they love to ask. But to go back to our patient who's in the office with us, Mr. Lane, what you tell Mr. Lane is that this does appear to be cellulitis, and it's likely due to either group A beta hemolytic strep, such as strep pyogenes, or Staph aureus. You probably wouldn't go into that much detail with Mr. Lane, but you get my drift. And because it's likely to be either a strep or a staph bacteria, you're going to be able to treat him with oral antibiotics. So you're going to prescribe him at least 5 days of cephalexin. At the same time, you're going to tell him that really this should improve within 24 to 48 hours. But if you're not improving in that time, you need to let me know, because then we need to think about other bacteria. I'm going to go ahead and mark this area so that we can monitor progress. Now, If you're not improving, or if you develop fever or other symptoms, you need to let me know, because then we need to think about doing something else. I don't need to put a needle into this area of skin. I don't need to do an x-ray or a CAT scan or anything like that. This is a clinical diagnosis. Now, one of the things I am going to do is, as I'm examining your leg, is we're looking to see if there's any break in the skin that might have served as an entrance for this bacteria to get in. And because I've looked in between your toe webs, I've been able to diagnose that you also have tinea pedis, so we're going to have to treat that as well. So our patient with cellulitis, he is going to do well. And in the next episode, we're going to talk about some other scenarios to be aware of.